All
Okay.
right. So
So,
good evening. Yeah. Oh, you were
evening.
going to introduce me.
No, that's
Okay.
fine. I want
To
people
the
to know
crowd.
who they're listening to. So, I am honored, actually. Thank you very much, Dr. Shemi, for this uh, lecture that you're going to give us. Dr. Shemi is a head and neck surgeon. She graduated in
المجموعة بتاعت
embry.
غزة كل شوية يعملوا محاضرات
Sorry. She graduated from Emory University in Atlanta, completed her otolaryngology training at Tennessee, and then has been since then working as a head and neck consultant there in Phoenix, Arizona. She's very kindly going to talk to us about something very interesting, and for me, it's incredibly interesting because from a Arabic side, very few of ENT actually end up doing head and neck and neck dissections. So thank you very much for giving us this lecture. We'd love to hear about neck dissections. Thank you.
Okay, wonderful. Thank you for the invitation. Um, I'm happy to be here and nice to see you all. So we're going to be reviewing neck dissections, the classifications, the indications, and technique. Wait a minute. As I began preparing this lecture, I realized it's really too big of a topic for a 1 hour lecture. So I've divided the discussion into two parts, and today we'll be reviewing part one. So I'm going to briefly go over the history of the neck dissection, and then we'll follow that with an anatomy review, specifically focusing on the different levels of the neck. As well as common nodal drainage patterns. And then we'll review the classifications of the various different types of neck dissections as well as their indications. And then in part two, we'll review technique, postoperative care, and complications. So the radical neck dissection was first described, at least this is the story that's told in the United States, that Kreil is credited with being the first surgeon to describe the radical neck dissection in the early 1900s. And the purpose of this operation was an in-block resection of all the lymphatics in the neck, in addition to their interconnecting lymphatic channels. And this operation, the radical neck dissection, became the standard of care for the next 70 years. But in addition to removing all the lymph nodes in the neck, important functional structures were removed, including the sternocleidomastoid muscle, the spinal accessory nerve, and the internal jugular vein. So in the mid 20th century, Suarez, another general surgeon at the time, discovered that the lymphatics of the neck are contained within fascial compartments, comprised of the fascia overlying the submandibular gland, the fascia overlying the carotid sheath, the sternocleidomastoid, and the fascia overlying those deep posterior neck musculatures and nervous structures. And he incorporated the knowledge of these fascial compartments as he planned his surgical approaches for his patients with head and neck cancer. As time went on, Doctors Boca and Pignataro continued the work of Suarez, and they coined the term functional neck dissection. So they routinely performed dissection of levels 1 through 5 of the neck and preserved the non-lymphatic structures whenever possible. This functional neck dissection, we come to know this as the modified radical neck dissection. And then entering into the modern era, we, as our knowledge and understanding of anatomy and predictable patterns of nodal spread for cancers based on their location in the upper aerodigestive tract, we realized that we don't have to dissect every single lymph node level for each and every head and neck cancer. And so from this, the selective neck dissection emerged. And we're going to review all three of these. But first, we're going to go over the anatomy, and I'm going to describe to you the different lymph node levels, their boundaries, and as well as important anatomic structures located within each level. And we will review their predictable patterns of metastatic spread. The lymph node levels were originally categorized by Memorial Sloan Kettering Cancer Center in New York. And this is a picture illustrating the 6 levels of the neck. So you see level 1 here, 2 here, 3, 4, and then 5 is the posterior triangle. Levels 1, 2, and 5 are further subdivided into A and B categories. And the key anatomic structures that distinguish these levels are the hyoid bone, the inferior margin of the cricoid cartilage, the posterior border of the sternocleidomastoid muscle, and the anterior border of the trapezius muscle. So we'll begin with level 1, which we also refer to as the submental and submandibular region. So the superior border of level 1 is obviously the mandible. Inferior border is the hyoid bone. The anterior border of the level 1 is the contralateral, the medial belly of the contralateral digastric muscle. So for left level 1, the anterior border is the right anterior belly of the digastric muscle. The posterior boundary of level 1, is the stylohyoid muscle here. So level 1 is further subdivided into levels 1A and 1B. Level 1A, we also refer to that as the submental triangle. And I'm going to go back to this picture because you really see it well here. So the submental triangle is here, located between the anterior bellies of the digastric muscle on each side and the hyoid bone. 1B triangle, and that is bound by the anterior and posterior bellies of the digastric, and also, to be more precise, the stylohyoid muscle back here is one of the boundaries, in addition to the mandible. Located within level 1B is the submandibular gland. So one of the most important anatomic structures that we encounter when we're doing dissections in level 1, whether that's for a neck dissection or excision of a submandibular gland, is the marginal mandibular nerve. And injury to the marginal mandibular nerve is the most common injury during a level 1B dissection. So it's important to be familiar with this anatomy. The marginal mandibular nerve is obviously a branch of the facial nerve. And it can be predictably inferior to the angle of the mandible, which would be about here. So here's the marginal mandibular nerve coursing inferiorly. And then it courses over the fascia overlying the submandibular gland before it ultimately reaches the depressor muscles of the lips and the mentalis muscle. The marginal mandibular nerve is in the subplatysmal plane, and it's located superficial to the investing layer of the deep cervical fascia that overlies the submandibular gland. It's also superficial to the facial artery and vein. And these are important things to know because they allow us to protect this nerve when we're dissecting in this area. So here you see a picture illustrating the submandibular gland here deep to the fascia, the investing fascia. And you see the marginal mandibular nerve here. And when you're dissecting, doing a neck dissection in this region, as long as you don't have to remove the lymph nodes around the facial artery and vein, then you can protect the marginal nerve by entering this fascia and reflecting it anteriorly, as you see here. And then you can ligate the facial vein, as you see it divided here. And as this is reflected superiorly, you see our marginal nerve is protected here, and then we can continue our dissection in this region. The hypoglossal nerve, the 12th cranial nerve, is another nerve that we encounter in level 1 dissections or excision of the submandibular gland. The hypoglossal nerve descends through the neck and it passes deep to the posterior belly of the gastric muscle, which has been transected here. But you can see the hypoglossal nerve here coursing inferiorly and then looping medially before it pierces or dives deep to the mylohyoid muscle here. You can see in this region, you have the lateral cornu of the hyoid bone. And so another operation where we encounter the hypoglossal nerve is the cyst trunk procedure when we do surgery for a thyroglossal duct cyst. And if you remember, when you remove a thyroglossal duct cyst, you have to also remove the tract, which involves transecting the mid portion of the hyoid bone. And so when you're dissecting along that region, when you're lateral, you'll often encounter the hypoglossal nerve. Common primary sites with to metastatic spread to level 1 include for level 1A, the chin, the lower lip, the anterior floor of mouth, the tip of the tongue, and the alveolar ridge. Level 1B, metastases typically come from tumors arising in the oral cavity, the floor of mouth, the oral tongue, the nasal cavity, and the midface. Cutaneous malignancies of the midface will often have metastatic spread to 1B. Level 2, we also refer to this as the upper jugular nodes, and this is bound anteriorly by the stylohyoid muscle, which we see here. Superiorly by the skull base, which we cannot see. This is the tail of parotid here in this cadaver photo. So kind of deep to this be the skull base, the superior limit of level 2. The inferior border of level 2 is the hyoid bone, which is around this region. But intraoperatively, we also will use the carotid bifurcation as an anatomic marker for the inferior border of level 2. Level 2 is divided into 2A and 2B, and these divisions are made by the their location relative to the spinal accessory nerve, the 11th cranial nerve. So I'm going to talk more detailed about the spinal accessory nerve when we get to level 5, but we do encounter and dissect along the spinal accessory nerve in level 2 region. So again, we would expect the course of the spinal accessory nerve to be somewhere like this. And then it would pierce the sternocleidomastoid muscle we see here before exiting posteriorly. So level 2A is the lymph node compartment superior to the spinal accessory nerve, and level 2B is the lymph node compartment posterior to. Level 2B is posterior to the nerve and level 2A is anterior to the nerve. Common primary sites that metastasize to this level are all of them really: oral cavity, the anterior nasal cavity, the nasopharynx, the oropharynx, the larynx, the hypopharynx, and the parotid gland. And so level 2 is incorporated into almost every neck dissection, except for super selective ones. Level 3, we also refer to this as the middle jugular lymph nodes. The anterior border of level 3 is the posterior border of the sternohyoid muscle, which we see here. This is the sternohyoid muscle. So the anterior border of level 3 is here. The posterior border of level 3 is the posterior border of the sternocleidomastoid muscle, which we see here. The superior aspect of level 3 is the hyoid bone. and the inferior aspect is the inferior border of the cricoid cartilage, or the intersection, sorry, there it is. The intersection of the, wait, I was on level 3. The intersection of the omohyoid muscle and the internal jugular vein, which we see here. In this photo, obviously, the sternocleidomastoid muscle has been removed. So common primary sites that metastasize to the level 3 lymph nodes include the oral cavity, the nasopharynx, the oropharynx, the hypopharynx, and the larynx. Level 4, we also refer to this as the lower jugular lymph nodes. This is bound superiorly by the inferior border of the cricoid cartilage. The inferior border of level 4 is the clavicle. The anterior or medial border of level 4 is the sternohyoid muscle, and the posterior border of level 4 is the posterior border of the sternocleidomastoid muscle here. So we see that here, and we see the sternohyoid muscle here, the clavicle here. And then structure that we need to be aware of when we're dissecting in level 4 is the phrenic nerve. And the phrenic nerve is the sole supply to the diaphragm. And it's made of cervical rootlets from C3, C4, and C5. And it runs in the neck along deep to the prevertebral fascia and along the surface of the anterior scalene musculature. It's also running posterolateral to the carotid sheath. So the times where we encounter, well, usually you should not encounter a phrenic nerve during a neck dissection, but sometimes when you're elevating your nodal compartment off of the floor of the neck, preparing to remove it from the neck, and you're dissecting posteriorly, sometimes if you're not careful, you can find yourself posterior to the carotid sheath, or inadvertently opening the prevertebral fascia. And that's when you run the risk of injury to the phrenic nerve. The thoracic duct is another important anatomic structure that we need to be aware of when we are operating in level 4, particularly on the left side of the neck. And the thoracic duct, you'll remember, it conveys lymph material from the entire body back to the bloodstream, with the exceptions of the right side of the head and neck, the right upper extremity, the right lung, the right heart, and a portion of the liver. The thoracic duct begins in the upper abdomen at the cisterna chyli, and then it travels superiorly. It enters the posterior mediastinum between the azygos vein and the thoracic aorta. So in this picture, the thoracic duct, you can see, is the green structure. It begins down here. It courses into the posterior mediastinum. It kind of juts to the left a bit, and it courses anterior to the vertebral artery and vein before curving and ingular vein, which has been transected here, and the subclavian vein. This is a structure that you really want to be cognizant of when you're dissecting in this region, because injury to the thoracic duct, you will know that that has occurred if your patient postoperatively develops a chyle leak. And you'll know they develop a chyle leak because what you see in those patients is you see high volume, usually a lot of chylous drainage filling your Jackson Pratt bulbs. And that can be managed either conservatively or sometimes requires a trip back to the operating room to control the leak. Level 4 common primary sites with metastasis to level 4 include the hypopharynx, the larynx, the thyroid gland, and the cervical esophagus. Level 5, we call that also the posterior triangle, and you can see that here quite clearly in this cadaver photo. The posterior border of the sternocleidomastoid muscle is the anterior limit, and then inferiorly the clavicle. posteriorly the anterior border of the trapezius muscle. So this is our level 5 posterior triangle. And level 5 is divided into 5A and 5B, and it's divided in relationship to the transverse cervical artery, which we see here. So 5A lymph nodes are those superior to the transverse cervical artery, and those are the spinal accessory nodes. There will be just a lot of lymph nodes along the course of the spinal accessory nerve. 5B are those nodes at or inferior to the transverse cervical artery. And just inferior to that, we also see supraclavicular nodes, including Virchow's node. And Virchow's node, I don't know if you're seeing this, if you can see posteriorly, but in this region is usually where we see Virchow's node. And when we see Virchow's node, when we see pathologic enlargement of Virchow's node, then we must think about metastasis from either the upper abdomen or the thoracic cavity, most commonly. The most important structure to be aware of when you're operating in level 5 is the spinal accessory nerve. So we talked about it when in level 2. The spinal accessory nerve exits at the skull base at the jugular foramen, and it passes near the digastric and internal jugular vein in this region. It travels deep in level 2 and then pierces the sternocleidomastoid muscle, where it gives off motor branches to the sternocleidomastoid muscle. It then exits posteriorly in a shallow path below the skin and the fascia. You can see in this picture the spinal accessory nerve here. It's quite shallow in the posterior triangle. It typically enters the trapezius muscle and then trifurcates to give off motor branches. And it usually enters the trapezius muscle about 5 centimeters superior to the clavicle. When you're in level 2, dissecting the lymph nodes, because when you're doing a level 2 dissection, you're really skeletonizing the spinal accessory nerve in that region. So you have to have a good understanding of the anatomy of the nerve and its anatomic variants. So most of the time, the nerve here runs deep to the digastric muscle and superficial to the jugular vein. So between the two structures, about 70% of the time. About 30% of the time, you'll see that nerve running posterior to both the digastric muscle and the internal jugular vein, as we see it here. And then rarely you will see the nerve actually pierce through the internal jugular vein. Common primary sites that metastasize to level 5 include the nasopharynx, the oropharynx, and cutaneous malignancies of the posterior neck and scalp. The last level of the neck is the central compartment, level 6, or some people refer to this as the compartment. And this is bound superiorly by the hyoid bone here, inferiorly by the suprasternal notch here, and laterally on each side by the medial border of the carotid sheath here and here. You'll see level 7 here. That's considered mediastinal disease, not part of the neck. So the central compartment contains within it the thyroid gland, the parathyroid glands, also parathyroidal lymph nodes, as well as paratracheal lymph nodes. Also part of level 6 is the Delphian lymph node, which you see here anterior to the cricoid cartilage. And when we see pathologic enlargement of the Delphian lymph node, then we have raised concern for an advanced thyroid malignancy or laryngeal malignancy. Common primary sites that metastasize to level 6 include the thyroid gland, the larynx. Both glottic and subglottic cancers of the larynx can metastasize to level 6, the apices of the piriform sinuses, as well as the cervical esophagus. So those are the levels. We've reviewed the anatomy and the common sites of the common patterns of predictable metastatic disease. And this is really useful information to have, not just in the operating room, but when you're evaluating patients in the clinic. And so this is a nice summary demonstrating. So if we see a patient in the office that has pathologic lymphadenopathy in level 2 here, then we are concerned primarily that this could represent a metastasis from the nasopharynx. 1A lymphadenopathy is actually, for early disease, is actually quite rare. When we do see level 1 lymphadenopathy, it's usually due to a lip cancer, an advanced lip cancer, lower lip. Level 1B, we see pathologic lymphadenopathy there, sometimes with metastasis from the anterior 2/3 of the tongue, the floor of the mouth, the gingiva, and the buccal mucosa. These middle jugular chain lymph nodes, we see pathologic lymphadenopathy here for the any portion of the oral cavity, the oropharynx, or the larynx. And particularly in this region, we see metastasis from primary tumors arising from the area of Wall-Dyer's ring. So nasopharyngeal carcinomas, tongue-based tumors, and tonsillar cancers. We will often see metastasis here. In the lower jugular chain region, that's when we start to wonder if maybe there's an underlying thyroid malignancy, advanced thyroid malignancy, hypopharyngeal or piriform sinus malignancy, and sometimes from the upper esophagus. And again, the posterior triangle, we see these most commonly with metastasis from the nasopharynx, also cutaneous malignancies involving the posterior scalp, the temporal bone, the ear, those regions. So before we talk about the different neck dissections, I wanted to review our nodal staging system for head and neck cancers. So NX refers to those patients in which regional lymph nodes cannot be assessed. N0 refers to patients who have no regional lymph node metastasis, and that can be either clinical staging, radiologic staging, or histopathologic staging. N1, patients who have a single ipsilateral lymph node that is less than or equal to 3 centimeters. N2 is divided into N2A, N2B, and N2C categories. So in N2A patients, they have a single ipsilateral lymph node that is between 3 and 6 centimeters. In N2B, they have multiple ipsilateral lymph nodes, but none of them are greater than or they're all less than or equal to 6 centimeters. N2C, those patients have bilateral lymphadenopathy or contralateral lymphadenopathy that are less than or equal to 6 centimeters. And in N2A, none of the lymph nodes can have extracapsular spread. N3 is where we see extracapsular spread. So N3A refers to lymph nodes that are greater than 6 centimeters but have no extracapsular spread. N3B is any lymph node, any size, with extracapsular spread. So now we've seen our patient and we know their primary site and their staging, and now it's time to treatment plan and decide which neck dissection, if any, they need. In patients who need neck dissections, we categorize them therapeutically. Well, in our treatment planning, we categorize them as either elective, therapeutic, or salvage. So elective neck dissections are those neck dissections that are planned as part of the treatment planning to address patients with head and neck cancer and a clinically N0 neck. So they have no known disease. So that's called an elective neck dissection. Therapeutic neck dissection is used when there is metastatic cervical lymphadenopathy and we are planning a neck dissection as part of their primary treatment plan. And then salvage neck dissection refers to patients who have undergone their primary treatment plan for their head and neck cancer. And after that is complete, they have either residual or new disease in the neck. And so then they undergo a salvage neck dissection. Neck dissections are further classified based on what is being removed and what is being preserved. So these include the radical neck dissection, the modified radical neck dissection, the selective neck dissection, and the extended neck dissection. And most of the time, almost always, when you're doing an elective neck dissection, it's also going to be a selective neck dissection. Therapeutic neck dissections can be any of these: radical, modified radical, selective, or extended. And then salvage can also be any of those, depending on the disease. So the radical neck dissection removes levels 1 through 5 in the neck, in addition to removal of the sternocleidomastoid muscle, the internal jugular vein, and the spinal accessory nerve, as well as the submandibular gland and the tail of parotid. It preserves the lymph nodes located in the postauricular region, the suboccipital region, retropharyngeal, those lymph nodes in the periparotid region, the perifacial region, and the paratracheal lymph nodes. The indications for a radical neck dissection are extensive nodal disease with extracapsular extension and typically involvement of the accessory nerve and the internal jugular vein. The radical neck dissection has significant morbidity associated with it because of the non-lymphatic structures that are removed. So in patients who have to undergo bilateral neck dissections, radical neck dissections, and the internal jugular vein is removed bilaterally at the same time, there's a significant risk for those patients to have facial edema and cerebral edema with increased intracranial pressure. Almost all patients, or all patients who undergo a radical neck dissection, will have shoulder weakness and pain, as well as reduced range of motion, and this is permanent. There's also more significant scarring and disfigurement from the operation because you're removing the sternocleidomastoid muscle. There's a depression in the neck that is pretty obvious. The modified radical neck dissection also removes all lymph nodes, levels 1 through 5, but preserves at least one of those 3 non-lymphatic structures, either the sternocleidomastoid muscle, the IJ vein, or the 11th cranial nerve, and it can be one or more of those. The indications for modified radical neck dissections are typically gross, visible lymph node disease affecting multiple levels. Modified radical neck dissections are further subcategorized depending on which structures are preserved. So, and it's not really important to remember these different types, because when you do these operations, the important thing is that you just dictate what you preserved and what you had to sacrifice in your operative report. But a type 1 preserves the spinal accessory nerve, but sacrifices the internal jugular vein and the sternocleidomastoid muscle. And this is done typically for operatively palpable nodal disease. Usually, honestly, it's rare to do a modified radical neck dissection for N1 disease, but N2A and 2B disease that does not involve the spinal accessory nerve. Type 2 modified radical dissections are where we preserve both the internal jugular vein and the spinal accessory nerve. And this is done, this is a primary operation that you want to do on a patient if the patient has very advanced disease on the ipsilateral side requiring ligation of the internal jugular vein, but they also need a therapeutic neck dissection on the contralateral side. You really want to try your best to preserve the contralateral internal jugular vein to reduce the postoperative morbidity and mortality. a type 3 modified radical neck dissection, we also call that either a functional neck dissection or a comprehensive neck dissection. And that is where levels 1 through 5 are dissected, and all three non-lymphatic structures are preserved. Occasionally, this is done for N0 neck, but it's also more frequently done for less bulky nodal disease, where the predictable patterns of spread dictate that you dissect levels 1 through 5. So in looking at the modified radical neck dissection versus the radical neck dissection, both of these operations actually offer similar oncologic results. So they have a similar overall 5-year survival of around 55 to 62%. They have a similar rate of 5-year local regional control, 75 to 80%, which is pretty decent. They also have pretty similar 30-day perioperative mortality rates, which is quite low, less than 1 to 2%. You do see higher mortality in these patients who either underwent bilateral modified radical or radical neck dissections where both internal jugular veins are sacrificed. And that mortality is in the rate of 10 to 14%, and that relates to the complications I mentioned earlier with increased intracerebral pressure. The differences in these two operations really lies in their morbidity. So the morbidity of the radical neck dissection is quite high. They have a high incidence, 47 to 100% incidence of shoulder pain and dysfunction, which is often permanent, as well as pronounced neck depression and asymmetry. Versus the modified radical neck dissection morbidity, there's a significant reduction in shoulder pain and dysfunction. And with proper physical therapy postoperatively, that can often be managed long-term. So the estimated long-term functional disability for modified radical neck dissection is around 42% and around 58% for a radical neck dissection. So it's statistically much better with the modified radical neck dissection, but still not great. We're going to move on next to selective neck dissections. But before we do that, I just wanted to mention the category of extended neck dissection. And the extended neck dissection can be done in other extended radical neck dissection, modified radical neck dissection, or selective. Extended means that you have removed something extra, whether that's retropharyngeal lymph nodes, paratracheal lymph nodes, mediastinal, sometimes for cutaneous aggressive, advanced cutaneous malignancies of the midface, or advanced parotid malignancies. Sometimes we have to do a parotidectomy, superficial or total, or sometimes we have to remove portions of skin, sometimes for cutaneous malignancies, or sometimes you can have such bulky cervical lymphadenopathy and advanced disease that has actually ulcerated through the skin. And so sometimes some of that skin has to be removed. So any of those would constitute an extended neck dissection. Moving on to our last category, selective neck dissections. So selective neck dissections refer to the in-block removal of one or more of the lymph node groups that we just discussed. And these selective neck dissections are most often done as elective neck dissections. So they are done for patients with N0 disease. But those patients who undergo these elective selective neck dissections, based on their tumor, the primary site and stage of their primary tumor, if they have a risk of 20% or greater of having occult nodal disease, then we routinely do a selective neck dissection. The levels dissected during a selective neck dissection depend on the primary lesion. So there are different types of selective neck dissections: supraomohyoid, extended supraomohyoid, lateral, posterior lateral, and anterior or central. And we'll go over each of those. the selective neck dissection that is done most commonly for oral cavity cancers that have a 20% or greater risk of occult nodal metastasis. So in a supraomohyoid neck dissection, levels 1 through 3 are dissected. So you can see 1, 2, and 3. So these are the limits of the supraomohyoid neck dissection. The indications for a supraomohyoid neck dissection are squamous cell carcinoma of the oral cavity, T1 through T4. N0 necks, they all get a supraomohyoid neck dissection. Also, the selective neck dissection in oral cavity patients who have low volume N1 disease are also candidates for supraomohyoid neck dissections. Supraomohyoid dissections are often done for patients who have bilateral N2C disease, who need the contralateral neck dissected, but may require a more extensive neck dissection on the ipsilateral side. And then an extended supraomohyoid neck dissection is most commonly done for cutaneous malignancies, squamous cell carcinomas or malignant melanomas in the pretragal area that are advanced and require dissection of the neck. And it's often done in conjunction with the superficial parotidectomy. Lateral neck dissections involve dissection of levels 2 through 4, which we see here, all the way down here. And these are done for primarily squamous cell carcinomas of the oropharynx, the hypopharynx, and tumors that are T2 to T4 that are N0. Selective neck dissections are often done for advanced cutaneous malignancies, and depending on the location of the malignancy, that would dictate which levels are dissected. But the posterior lateral neck dissection refers to a neck dissection that is most commonly done for cutaneous malignancies involving the posterior scalp and upper neck. So the superior limit of this dissection is the skull base anteriorly and the nuchal ridge posteriorly. The inferior limit of the dissection is the clavicle. Posterior limit of this section, and this is where selective neck dissection is. The posterior limit is the posterior edge of the trapezius muscle. And in this dissection, the lymph nodes, the periauricular lymph nodes and the suboccipital lymph nodes are also dissected. So lastly, the central compartment. The central compartment is dissected for cancers of midline and anterior lower neck structures. So most commonly, the most common indication for a central compartment neck dissection is thyroid cancer. But sometimes it is also done for advanced glottic cancer or subglottic cancer, also cancers that involve the apices of the piriform sinuses or the cervical esophagus. And a level 1 dissection can sometimes be done as an isolated procedure or sometimes in conjunction with removal of other levels of the neck. So the superior limit of dissection is the hyoid bone. The inferior limit of dissection is the suprasternal notch. And laterally, the limits of dissection are the medial borders of the carotid sheath. It's most commonly done as a bilateral procedure. Because there's continuity of the central compartment lymph nodes. There's not really a fascial division between the left central compartment and the right central compartment. So most commonly, both sides are dissected. And there's lots of important structures located in the central compartment, including the thyroid gland, the parathyroid gland, the recurrent laryngeal nerves, and the superior laryngeal nerves. When you're doing a level 6 dissection, you're really skeletalizing along the recurrent laryngeal nerve to do an adequate oncologic procedure. But still, the risk of injury to the recurrent nerve during that dissection is around 2 to 4%. The greater risk during a central compartment neck dissection is hypoparathyroidism, because you are really dissecting, you have to dissect out the parathyroid glands, all 4 of them, and really run the risk of devascularization. So oftentimes in a central compartment neck dissection, the surgeon will electively remove the parathyroid glands and implant them into the sternocleidomastoid muscles so that they can revascularize there. Otherwise, you run the risk of leaving them in the central compartment and they all necrose, and then the patient has permanent hypoparathyroidism. So the efficacy of the selective neck dissection, there's actually quite a lot of data on this, but I'm choosing to highlight the MD Anderson Cancer Center experience. So in their experience of volumes of selective neck dissections for N0 cancers of the upper aerodigestive tract, there's a 5% risk of recurrence, which is quite low. For patients who have a single nodal involvement, that risk of recurrence is still low, 10%. The risk jumps dramatically in patients who have multiple positive lymph nodes or have any lymph nodes with extracapsular spread. And in those cases, the risk of recurrence is around 24%. So 1 in 4 of them, which is significant. And so in those patients, up with post-operative radiation therapy, and that drops the recurrence risk to 15%. So there's very clear data, very strong data supporting selective neck dissection in patients with the N0 neck. And just to recap on that, selective neck dissections are offered for patients who have N0, no clinical evidence of neck disease, but their primary tumor tells us they have greater than 20% risk of occult nodal disease. And just to summarize what we just went through, the oral cavity, typically the selective neck dissection for oral cavity is levels 1 through 3. Oropharynx is level 2 through 4. Hypopharynx is also typically level 2 through 4. Sometimes, depending on the primary tumor, sometimes level 6 has to be dissected. The larynx is typically levels 2 through 4. And nasopharynx in patients who are N0 with a nasopharyngeal malignancy, those patients, to address their risk of occult nodal disease, they typically undergo radiation therapy rather than a selective neck dissection. The efficacy of selective neck dissection for node-positive disease, there's a lot of data, but it's not as black and white as the data for N0 necks. So I've highlighted 2 studies here. Anderson and colleagues in 2002 did a 10-year multi-institutional retrospective review where they looked at 129 patients who underwent selective neck dissections for node-positive disease. And they found of those 129 patients, 9 of them had recurrence. So that's a 94.3% regional control rate, which is quite good. Another study was done by Hashmi and colleagues in 2022, and this was a retrospective cohort study where they compared patients with oral cavity squamous cell carcinoma. Some had node positive disease and some had node negative disease. They all underwent a selective neck dissection. They looked at 111 patients. 62 of those patients were N0 at the time of surgery and 38% were N positive. And their regional control rates were similar among the 2 groups, 95% versus 96%. So no statistical difference there. And their overall disease-specific survival was also similar, 84.5% versus 82.5%. So in carefully selected patients, the selective neck dissection is a safe and oncologically sound operation, and it definitely offers the reduced morbidity and mortality. patients who undergo selective neck dissections where levels 2, 3, and 5 are dissected, even just 2 and 3, they will have shoulder pain and some immobility postoperatively, because as I mentioned, when you're dissecting in these regions, you're really skeletonizing that nerve. So they very commonly have some weakness and pain after surgery. They undergo physical therapy routinely, but they typically recover and do quite well. So in summary, our goal when treating patients is we want to, when we see patients with head and neck cancer, we want to do the most oncologically beneficial operation that we can offer them while preserving function and quality of life. And so a knowledge of the anatomy matters, so that we can understand the nodal patterns of spread and predictable patterns of metastatic spread, as well as our understanding of the disease. As that's advanced, it's allowed us to become more conservative in our surgery, which is offering our patients an improved quality of life. So that's what I have for today. I'm happy to answer any questions.
Thank you very much, Dr. Shami. That's a very comprehensive start for the discussions.
It's a lot of
Okay.
anatomy.
Yeah, no, but it's very good, very good. So, come on, guys, questions.
Okay, when I come in October, I expect a list of questions. Thank you all for coming and listening.
Can I ask you a question? So,
Yeah, of course.
and there's a reason behind the question. So, you very kindly gave the studies that looked into how the selective necks would end up, well, giving you a good result, and then the ones that are a little bit more, you thought about, okay, fine, we'll give post-op radiotherapy, and that will decrease it from 20 something to about 15. The flip side of the coin, an N positive patient ending up having radiotherapy without the neck dissection. Would you ever do that? And I know that we do it here sometimes in the UK, but would you do it? And if you do it, do you expect the same result? Approximately.
So sometimes, and this is a very kind of generalized lecture to sort of introduce these concepts and remind us of all these concepts, but there are certainly many, many nuances. So yes, surgery isn't always the primary modality, the primary treatment plan. So yes, sometimes radiation therapy or chemoradiation is offered to our patients, and not always do those patients require salvage neck dissections.
Reason for the question is that, well, I hope and I wish that one day the team there will be able to do neck dissections, is because actually
Me too.
if they manage to do neck dissections, one of their biggest problems now is they don't actually have radiotherapy at all. As in,
Right.
that is not even an option there. So actually,
Right.
talking about neck dissections is actually has even a higher priority there than we even have it in the in the UK or the US or something like that, because our
Yes.
patients sometimes have the option of going with a chemoradiotherapy, as you said, or something like that. But
Mhm.
but
Yes, but they don't have that in
they
Gaza.
don't have it there. So actually, them learning to do neck dissection might actually be the savior for their neck positive patients
I think so,
over.
and certainly the N0
Yeah.
patient. So if they're seeing, patients who have early tongue lesions or oral cavity lesions and, have a risk of occult nodal disease of 20%, offer them a selective neck dissection, because then hopefully they won't need to have radiation therapy down the road for a recurrence.
Yep.
Mm-hmm.
Absolutely. So that's why I think, it's very relevant for them to try and do that. Okay, any questions?
Yes.
Or are you actually saving the questions, as Dr. Shami said, till October when she actually goes there and sees you in person? Okay.
Anyway, I know Dr. Sami is working, so he's logged in, but maybe he's off seeing a patient.
Yeah.
They work very hard. They work too hard. So I'll happily do this discussion again in October.
I
Okay.
have a question, Dr. Halla.
Hello.
Hello, Dr. Abdelhadi, with you?
What? Oh,
I'm
hello.
asking
How are
about
you?
for the patient with N0. You in your lecture you say that many types of cancers need selective neck dissection for N0. So which patient will need neck dissection with N0? It's just for the oral cavity, or can be to the larynx or nasopharynx?
Okay, so the oral cavity, typically a selective neck dissection is recommended for T1. So any T tumor of the oral cavity, typically a neck dissection, a selective neck dissection is recommended for that. For oropharynx and hypopharynx, usually if it's T2 to T4. And obviously these are generalizations. So we're always looking at, location, whether it's midline, those sorts of things, to tailor the operation for the patient. But just as a general rule, T1 oral cavity tumors and T2 or greater oropharynx, hypopharynx, larynx tumors need selective neck dissection. And sometimes those patients will be offered radiation therapy versus a selective neck dissection, but we don't have that in Gaza. So those patients, something needs to be done about their neck. Does that answer your question? And for nasopharynx, because those tumors are sensitive, if you have a patient with a T1 nasopharyngeal cancer, they would still they would be recommended actually radiation therapy over neck dissection.
Yes, thank you.
Yep, you're welcome. And we have a lecture lined up on radiation, principles of radiation therapy for head and neck malignancies in our department lecture series. So that's coming up. It's on the horizon. You'll get more detail about that. Anything else? Well, thank you so much. It's good to hear your voices.
Thank you
We'll
very
see you
much.
soon.
Thank you very
My
much.
pleasure.
Thank you.
Good night. You're welcome.
Okay.
Bye.
Thank you.